Good morning and welcome to Community and Health Services Committee meeting for Wednesday or Tuesday, March the 10th. I'd like to now call on Tim Brubaker, Regional Clerk, to conduct the roll call.
Thank you. Regional Chair Redmond.
Present.
Councillor Craig. Chair Erb.
Present.
Councillor Foxton.
Present.
Councillor Gowing. Councillor Harris.
Present.
Councillor Hunick.
Present.
Councillor James.
Present.
Councillor Liggett.
Present.
Councillor McCabe. I heard Councillor McCabe. Councillor Nowak. Councillor Rodriguez. Councillor Salonen. Councillor Shantz.
Present.
Councillor Ravanovich. Councillor Wolf. Thank you, Chair.
Thank you. As we begin this meeting, we are again reminded that many of our homes and places of employment in Waterloo region are situated on the land that is the traditional territory of the Haudenosaunee, Anishinaabe, and Chinatown peoples. We recognize and deeply appreciate their historic connection to Waterloo region, and we also recognize the contributions Indigenous peoples have made in shaping and strengthening this community. We are grateful for the opportunity to live and work here and reaffirm our collective commitment to keep the promise that reconciliation takes place through learning and community building with Indigenous people who continue to live here. We are all treaty people with a responsibility to honor all of our relations. Are there any conflicts of interest under the Municipal Conflict of Interest Act? None. We have no presentations. We have no delegations. We can move on to agenda item 6.1, strategic priority, homes for all. I'd like to invite Julie Wheeler, Director of Senior Services, to the podium to introduce our report.
Thank you, and good morning, members of the Health and Community Services Committee. My name is Julie Wheeler. I'm the Director of Senior Services. The Senior Services Division works to support adults and older adults to age in our community with dignity, ensuring that there are spaces and places where people feel listened to and cared about. Here today, I'm so pleased to be introducing you to Dr. Fred Mather, who has been our medical director for over 30 years and has worked in the long-term care sector for over 40 years. Since we were last here, Dr. Mather was the recipient of the King Charles Coronation Medal in recognition of his tremendous contribution to the long-term care sector here in our community, in the province, and across Canada. We have the great joy and privilege of having Dr. Mather as the medical director for the regional home, Sunnyside Home. And so we're really pleased to have Dr. Mather here this morning to share with you a report on how things are going at Sunnyside Home in the last year.
Welcome, Dr. Mather.
Thank you, Julie, and it's my pleasure to return here and give an update on what's happening at Sunnyside Home. And I will conclude with some reflections about long-term care in Ontario in general. I'll touch on these things briefly, changes in the data analytics, the collection and reporting of quality data in long-term care, the exciting living classroom that we have at Sunnyside Home for training personal support workers, research project which is just getting underway on trauma-informed care and long-term care, and an update on advanced care planning and consent. Next slide. The vision is a caring community where everyone can live their best lives. Next slide. The vision is achieved through providing the highest quality of care and service, creating an inclusive, thriving, and welcoming community, and inspiring people to live hopeful, happy, and healthy lives. Next slide. So Sunnyside provides a spectrum of care. We have the housing for seniors, affordable housing, supportive housing, long-term care, and community programs. And I would particularly emphasize our community Alzheimer program, which is very well used, and associated with that is respite care where the same individuals that may come for the daycare programs can also have respite care, where a caregiver may be on holidays for a week or two or just needs a break, and it's the same staff that's providing their care and respite care as they are in the day program. Next slide. So just a bit on data analytics and long-term care. Long-term care in Ontario is heavily regulated, as I'm sure you all know. Long-term care sits at the intersection of healthcare, housing, and human rights, caring for a population that is both medically complex and structurally vulnerable. In the past year, the collection of data in the Inter-RAI system has undergone a change to Inter-RAI long-term care, which gives us more timely and specific data. As an aside, an international researcher and leader in the Inter-RAI system is Dr. John Hurdes at the University of Waterloo, and he was recognized with the Order of Canada for his work here in a couple of years ago. So also the other change too is how our quality indicators are reported, and they're reported at the Canadian Institute for Health Information site, which is accessible to all the public, and it compare the the Canadian quality indicators with the province and also with individual homes. Next slide. I want to just highlight the two quality indicators that are encircled in red there. The one on the far right is the use of physical restraints in long-term care. And the number for Sunnyside is 1.7%, which, if you recall the previous slide, it was 1.4 for the province, so we're at much the same level. But this is something we have addressed, because when we looked at it a few years ago, by having comparative quality indicators, we were more around 6 to 7%, which we felt was unacceptable, and we've had a quality improvement program to bring it down to the current level. We've also just finished a similar effort to minimize, almost eliminate the use of bed rails at Sunnyside Home. Although very common in the hospital environment, physical restraints and bed rails are frowned upon in long-term care, not only because they restrict freedom and mobility, but the risks then outweigh any possible benefits by being a potential cause of serious injury. The other data I've highlighted there is our potentially inappropriate use of antipsychotic medication, which is 14.9%. On the previous slide, which was the Ontario number, it's more around 20%. It's something we've managed to keep low and much lower than the local, provincial, and national levels. And it's one thing that the media in particularly looks at when they're looking at care in long-term care homes. Next slide. So the Living Classroom is an innovative educational partnership between the Region of Waterloo, St. Louis Adult Learning Centre, and Continuing Education Centres, and is a dedicated space where public support workers are trained through hands-on learning, mentorship, and deeper engagement with residents. The initiative is part of a broader province-wide trend to integrate education in long-term care homes to better prepare healthcare workers. Next slide. This is a group of the initial group of students who are, there were 16 altogether that graduated, and they gave overwhelming positive reviews of the program. Next slide. And it was a very positive experience for them, looking at the feedback we received. Next slide. And this is the next group of graduates. Personal support workers are very important members of the healthcare team. In fact, I would say they're the most important ones, because they're the ones that give the most attention to the day-to-day care of the residents. Their training is very important. Since the Fixing Long-Term Care Homes Act was passed in 2021, there's that requirement that every resident gets 4 hours of personal care. So there's been a real demand to increase the pool of PSWs there, and this is how we can contribute to meeting that increasing demand. Next slide. A research project that is just getting underway. It's a 4-year research project in which we have received funding through the Canadian Institute of Health Research and the Canadian Consortium on Neurodegeneration in Aging is trauma-informed care. Trauma-informed care in long-term care setting is an approach that recognizes the widespread impact of trauma among older adults and seeks to create care environments that promote safety, respect, choice, and empowerment, while actively working to prevent re-traumatization. Many older adults experience traumatic events over their lifetimes which affect their responses to care and their reenactment of trauma when they may enter an institutional setting. The chief investigator of this is with Dr. Sophia Benjamin, who's a geriatric psychiatrist here. It is what's called an open design type research project where the initial phase is, which will get underway this year, is interviewing residents, substitute decision makers, staff, and management about what their understanding is of the impact of trauma in the residents that we look after. And then the next step will be to look at ways of increasing awareness of the care staff in dealing with trauma-informed care. Next slide. And I just wanted one thing that we need to provide ongoing education, leadership, and action is the whole topic of advanced care planning and consent. This is something that the region of Waterloo was a real leader in the 1990s. Some of you might recall these forms that were used in the emergency departments in hospital, in home care, in family physician's office, and in long-term care to provide means of making decisions as to what you would like for your care or the person that you're the substitute decision making for if they're approaching end of life or have a significant change in their condition. Next slide. Now, these forms, unfortunately, although they were widely used and people would have them on their refrigerator, for example, just in case they had to go to the emergency department and they had their choices for aggressive or less aggressive care clearly stated. However, with the passage of the Substitute Decisions Act and the Healthcare Consent Act, they were considered not appropriate forms because they implied consent, and according to the Healthcare Consent Act, consent needs to be always time-specific and decision specific. So we've gone from talking about levels of care or advanced directives to advanced care planning, goals of care, and whatever is provided in terms of care requires consent, again, which is both time-specific and decision-specific. So we are underway in 2026 to review our own policy on advanced care planning. Next slide. And we created this a few years back, and it's due for some updates. Our policy is consent is a conversation, and it's based around 3 general, simple, but important questions. Who will make decisions for me should I be unable to make them myself? Do I want to be resuscitated, that is CPR, if my heart and breathing stops? And 3, where would I like to be cared for when my condition changes? Okay, I'd like to just thank Julie for her introduction. I was honored on March 29th last year to receive the King Charles III Coronation Medal for my work in long-term care. It was presented to me by the minister, Natalia Kusendova-Bashta. I was also honored in October to give the keynote address at the Ontario Long-Term Care Clinicians annual convention. I was asked to give the history of the Ontario Long-Term Care Physicians, which was a charitable organization which became in 2016 the Ontario Long-Term Care Clinicians under my leadership, a not-for-profit which now provides a lot of advocacy and education, in particular the medical director course that is mandated in the current act. Throughout my preparation and the feedback I've received since then, I came to the revelation how significant the decade of the 1990s was for long-term care. We saw it particularly here in Waterloo region, where there was the closure of chronic care hospitals. Freeport Hospital at that time had over 300 chronic care beds, which were closed throughout that decade. Many of those patients in Freeport became residents in chronic care with a higher acuity of problems with catheters, feeding tubes, and complex wounds. We also saw the repatriation of long-term mental illness patients from the geriatric psychiatric units at St. Thomas and London Psychiatric Hospital coming back into long-term care. And there was that ongoing process of the closure of the old Ontario hospital schools, the big ones being in Blenheim, Aurelia, and Smith Falls. And a lot of those people, though most of them actually went into community living, which was very good, some had complex medical needs and went into long-term care. We also saw a marked expansion of long-term care, and long-term care became very, very restrained, and it took another 20 years and the COVID pandemic to realize how strained staffing and resources were in long-term care, which has led to, I think, a turnaround in the last few years as we've seen the changes with the Fixing Long-Term Care Homes Act. One other change that I just mentioned, and this is why this body and the region is so important in long-term care, is that back in the 1990s, almost half of long-term care homes in Ontario, which included at that time homes for the aged, which would have been the term used for Sunnyside, were operated by the public, by municipalities. And then there became a large degree of private ownership of long-term care. And now municipal homes account for 16% of the homes. And there hasn't been any increase in municipal homes, although they are considered the exemplary homes. And I'm pleased to be working with medical directors of the 2 homes in York Region, the 4 or 5 in Toronto, Wellington Terrace in Fergus, as homes that will provide examples of quality care in long-term care. So thank you for letting me give you this update. It's been it's been important for me to share all this with you.
Thanks, Dr. Mather. Don't go far. We have some questions for you. First, Councillor Hunick.
Thank you, Chair Erb, and thank you, Dr. Mather, for your work in our community and our regional home, as well as your great report today. I'm particularly passionate about the reduction of physical restraints, and Sunnyside being noted for that. Thank you for that work. I'm also passionate about ensuring that safety standards are the same across regional services, including Mobility Plus. Could you clarify, according to the Ministry of Long-Term Care and therefore Sunnyside Home as well, could you clarify, are lap belts on wheelchairs considered a physical restraint?
That's a very good question, and it's a matter of interpretation. If the resident can release the lap belt, it's not a physical restraint. If they can't release it, it's considered a physical restraint. There is some nuance there, and explains some of the variation in the data, though. And it requires a critical review in some cases, because there's also the personal assistant safety device, where it's done more for reasons of positioning or comfort.
Right.
Long-term care homes get a lot of inspections, and that's something that the inspectors look at. It may be classified as a PASD, but in reality, it may be restraint. So there is, I'll just say it again, there's a bit of a nuance there, how that's interpreted. But anything that a resident can't free themselves of would be considered, strictly speaking, a physical restraint.
Thank you. Your wisdom will be noted for a Mobility Plus discussion later today. Appreciate it. Take care.
Okay, thank you.
Councillor Gowing.
Thanks, Chair. Thanks for bringing this in. I always love visiting Sunnyside, and especially the new Alzheimer's Society, chapter that you have there. One of the slides that you had there, it mentioned potentially inappropriate use of antipsychotics in long-term care. The title of that, to me, struck me when I read that. Can you explain it a little more? Because, potentially inappropriate use, just...
Thank you for the question. What is appropriate use? There's about 5 indications for appropriate use: schizophrenia, Huntington's dementia, hallucinations, delusions, and end of care, where they're used mainly for off-label reasons at that time. So those are the appropriate ones. The potentially inappropriate ones are the ones that don't fall into those 5 definitions. But they may include what would be medically considered very appropriate. For example, for major depression and bipolar illness, antipsychotics may be either first or second line treatments for them. But what is particularly focused on in long-term care, that is they're not abused, is when it's used for aggressive behaviors in dementia, like Alzheimer's disease. And they may have a role there, but it's felt to be a very limited role. And that's what's especially looked at with that quality indicator.
Okay, thank you. That clears it up.
Councillor Liggett.
Thank you, Mr. Chair. I have a couple, but one was connected to what Councillor Gowing had asked. So if antipsychotic drugs are, you're trying not to use them, and also restraints are trying not to be used, how are you taking care, making sure people are safe? Like if somebody gets up in the middle of the night to use the washroom, I mean, we all have heard those stories. Or we have relatives who've got up to go to the bathroom unassisted because they feel they should be able to do that, and then they fall and break their hip. So how are you dealing with that one? And then if you don't mind, I'd like to do my follow-up question after that. Sorry, my other question after that.
The real emphasis is on non-pharmacological interventions. So for the person who's getting up at night, and they may be very confused and very high risk for a fall, they would have a bed alarm. So when their weight shifts off the bed, an alarm goes off, and a PSW or a nurse on the floor would come to assist that person to go to the washroom. In terms of bed rails, which can cause very serious injuries in the cognitively impaired person, having a low bed where there's mats beside the bed, so if they were to slide off. So sometimes where they're needed to help with transfers in bed, like in a partial paralytic patient, using like a fireman's pole beside the bed is a safer technique than having a bed rail up.
May I ask my next question? Yeah. I'm particularly interested in the living classroom as well as the research in trauma-informed care. we're hearing more and more that our long-term care facilities are taking in patients or clients who have mental health issues or addicts, and that there's problems within those places for the elderly who don't have those problems. In particular in BC, I hear it's been going on for quite a while, and I know it's happening in Ontario now. The living classroom, if you're dealing with PSWs and their training, are they being trained in that themselves and de-escalation? Like, how does that work? And could you speak to the research in trauma-informed care and how that is applied there?
Okay.
Thank you.
So the first part of your question is the training for the PSWs. I can't really go into all their curriculum because I'm not directly involved with it. But yes, it does deal with the spectrum of mental illness in long-term care, people with serious mental illness, people with schizophrenia, bipolar disease, schizoaffective disease in long-term there, that they can recognize them and the behaviors that may be associated with that. And also probably a much larger group of challenging residents are people with more advanced dementia where they have inappropriate behaviors, aggressive behaviors, loss of frontal lobe inhibition where they can make inappropriate comments of a sexual or racist nature. That's all part of the training. With the research in trauma-informed care is looking at probably a wide range of trauma, and that's part of the phase one. When we think of past trauma, we think of the effects of war, displacement, abuse, physical, sexual, emotional, and but also there's other trauma. Part of this that I'm particularly interested in, and I think we can look at in this project, is the effects of the trauma of the COVID-19 pandemic, because I think that took a big toll on people, the isolation, the lack of visitors during that time. And if we were to have another major pandemic like that, we might want to reconsider the severity of the restrictions of individuals living in long-term care, because I think there's sort of an untold toll that took on individuals in long-term care. The research project itself is a matter of interviews, getting the attitudes and the opinions of staff, residents, caregivers, and then developing tools for education and assessment of residents in identifying the impact of past trauma into their current health situation, and also the impact of institutionalization. To go back to studies that were well published, the works of Dr. Michael Gordon at Baycrest, for example, because for decades he worked with Holocaust survivors at Baycrest in Toronto, and his work identified the impact of their experiences in concentration camps and post-war diaspora on their experience of going into an institution then later in life. That's a very dramatic example, but that's the type of information we want to get, or look for the information from an individual's past that we might be missing right now.
So to deal with the part of my question that looked at those who had addiction issues where it's affected their brains, and they're much younger age group, but they have the strength of a much younger age group, and it puts at risk those in these facilities. How are you, is that part of your research in trauma-informed care, or how are the PSWs being trained to handle that?
I'm not sure if the particular resident you're referring to would be best served in long-term care. They may be better off in specialized mental health or in complex continuing care, the types of programs we have at the Wren Chicopee site right now. every resident has a care plan, and a care plan applies to the whole members of the team, and particularly the PSW. And resident on staff injury is a very important thing, so it would be part of the care plan, and the PSW would be trained on knowing what the care plan is and knowing what protection they need to take.
So we don't have any of those types of patients in Sunnyside? I'm asking because I know some long-term care facilities are taking more and more because there's no place for them to go.
Yeah.
Yeah.
We do have the type of resident that you describe, yes.
Okay, thank you.
Yeah.
Chair Redmond.
Thank you, Chair. Dr. Mathers, you're like the most interesting professor that I ever had in university. You're as perennial as the seasons, and I want to thank you so much for your dedication and your wisdom and your leadership in the health sector.
Yeah.
I've had some really interesting conversations about AI and how it relates to long-term care and specifically to Sunnyside. And I think it was Trinity where I first was introduced to smart toilets, but I was also told that Sunnyside used AI as one of the ways to augment patient care. So I don't know if this is a question for you, Dr. Mather, or for Julie, but can you talk a little bit about how AI is enhancing how we care for the residents of Sunnyside?
I will pass that off to Julie. It's a very good question because AI has transformed medical care in the last couple of years. We saw the evolution from textbooks to more online learning, and now it's generative AI and good resources. It's changing medical care. It's changing medical education greatly. From a personal point of view, I'm part of most physicians now who are using AI Scribe to some degree that helps to organize your observations, your physical findings, your investigative results, which makes for much better record keeping overall, recognizing at the same time all the pitfalls that generative AI may have. Julie?
Yes, through you, the chair. Thank you for the question. Full honesty, I think when it comes to AI, we are still much further behind than what I think the opportunity is for us. We have been involved in some work using robotic companions for a tool for engagement, which going back to what Dr. Mather said earlier, we are very motivated to overcome the isolation and loneliness that people feel in long-term care. And I think the pandemic put a burning platform underneath us to try to figure out ways to help people engage no matter what their circumstances are. And so we do see that technology has that option, and in particular AI, where we can have and access resources for people now to engage with the world outside of Sunnyside, and even within. And so very early in our process, but working with a few partners to start to explore options for I almost said a much cooler, that's not the word I should use, a much more modern opportunity to expand what we're currently doing.
Thank you. I knew Sunnyside would be on the cutting edge.
Councillor Schatz?
Thank you. Thank you, Dr. Mathers, and congratulations on your award.
Thank you.
Really appreciate the update on Sunnyside Home. The work you do there is amazing and I think very forward-thinking. I'm not sure if my question is for you or for Julie or for Dr. Wong, but I'll ask it and you can decide who should answer it. I know that there are other long-term care that do good research work as well. And of course, there are some that don't. So I wonder, what is our role at Sunnyside in terms of interacting with other long-term care facilities in the region, and how do we kind of support each other and learn from each other?
I'll let Julie answer that in greater detail. I told you about the traumatic informed project that we're doing, and it's done in collaboration with other homes, two other homes. In this case, the Hill Lodge in Ottawa and St. Joseph's Long-Term Care in Guelph. So we're definitely working together.
Well, I love the question, so thank you for asking it. From my perspective, and I think from the perspective of our team, we feel very strongly that as a municipal long-term care home, we have a responsibility to share and spread the opportunities and the learnings that we have within Sunnyside. And the Living Classroom is actually a beautiful example of that, where we really saw the opportunity to partner with the Sunnyside Foundation to create a space where people can come and learn about person-centered care, work alongside our residents and learn with them and from them, and then work wherever they choose in the health system. We obviously hope that people choose Sunnyside, but honestly, the goal is to create better learning opportunities so that we can inspire more and more people to choose healthcare. And that commitment extends to a number of different things. We have about 200 students that we accept annually in every discipline that you can imagine. We also take a very active role with Advantage Association, which is a partnership of municipal and not-for-profit homes, and encourage our team to be leaders in those opportunities, share what we're learning, share our resources and our policies where appropriate, and learn from others, because the opportunity to do better in healthcare is always present.
Can I follow up on that? Thank you for that, and I appreciate that we're working with other municipal long-term care facilities, but I'm thinking of also our private homes here. Do we have any role to play there? I know, for example, I've toured the Schlegel Research Institute, and they have a similar learning center and have had for a number of years. So how do we work together to share information and share learnings?
Yes, very much. And I think that each aspect of the long-term care sector brings a contribution that's valuable. For myself personally, I co-chair the Long-Term Care Advisory Table, which is made up of a variety of long-term care representatives from all aspects of the sector, as well as a local long-term care network. I think I see this as a really important role of myself and other members of our leaders on our team to be at those tables and to share experience, but also to understand the perspective of the private sector and what experiences they're having and what can we learn from that part of the health sector. It's truthfully a very challenging service to deliver on, and some of the questions today I think really pointed to that the regulations that we operate under are very, very restrictive, and what we need is creativity and innovation and leaders sitting at every table possible to learn and make the system better.
I don't see any other questions. Thank you both for attending and for the work that you're doing at Sunnyside. And I think, Dr. Mathers, you're probably the most senior person in this room right now who have been coming back here reporting on a regular basis. So thank you for being here again.
Okay, my pleasure. Thank you.
Item 6.2, the food safety program, so that report on Sunnyside Home was for information purposes only, no action necessary. Item 6.2.1, the food safety program, and I'll call on Dr. Wong, our medical officer of health, to introduce the report. And this one is for information as well.
Thank you, Chair, the members of Council, for the opportunity to provide just some overview remarks. So today, Public Health is providing members of Regional Council as the Board of Health with the annual update on its food safety program. Food safety is a core public health service, and it's also one of the most visible ways residents experience public health in their everyday lives. This report outlines key program activities in 2025 which ensure compliance with provincial food safety regulations and the Ontario Public Health Standards. This includes routine inspections of food premises, investigation of complaints, review of special events, and facilitation of licensing requests. Waterloo Region has in recent years experienced strong population growth, resulting in an increase in the number and complexity of food premises, inspections, investigations, and requests for service. In addition to routine inspections of food premises, growth has also led to public health inspectors managing an increase in volume of work in other program areas, such as rabies investigations, outbreak management, and other unscheduled priority demands. As a result, public health continues to implement a risk-based approach to prioritize inspections and reduce potential health impacts on the community. Public Health is grateful for Council's support in adding 2 public health inspector positions in 2025. These positions supported public health to maintain high levels of service in a growing food safety program while managing increased demands across all program areas and supporting public health's local response as well to the provincial measles outbreak, for which 4 public health inspectors were temporarily redeployed in 2025. Thank you. We also have Director Aldo Franco and Associate Medical Officer of Health, Dr. Rabia Bana, here in case there are questions.
Thank you, Dr. Wong. Councillor McCabe.
Thank you very much for the report and for the update and for all the work that happens through this program to keep people safe. I'm just curious about when or how often forms and things that business owners have to complete to apply for, licensing and the regular checks and things like that. Like when are those forms looked at and reviewed, and do you include business owners in that? I'm just thinking of, business owners, particularly in restaurants and coffee shops and things like that. They're small business owners who are very, very pressed for time, and their margins are really thin. So I'm just thinking of how frequently do your staff meet with some of the, or do you meet with them to, streamline forms, kind of alleviate any kind of bottlenecks, et cetera? Thanks for providing a bit of information around that.
Oh, thank you for the question, through Chair. Actually, business licensing goes through the local municipalities. We don't.
Oh my God.
We get requested for inspection.
Right.
Yeah.
But on the food inspection side.
From the food inspection side, anyone who wants to operate or begin an operation, they should be informing us of their intent to operate. So we have all that information up on our webpage, and it's an e-form that they can fill out, and if they want assistance in using another way to inform us, they can just call in as well, and we would review it. That's part of some of our requests for service is providing that assistance to whether in consulting when someone wants to open up a new business, or to inform them of what they need to do and how we can help them support their new business.
Thanks for that. Maybe, I apologize, I maybe wasn't clear. I'm just, the forms and the processes that you use for, food safety,
right,
whether it's for an event or for the restaurant owner as they're setting up, et cetera. I'm curious if you sit down with, a group of them from across the region at any, yearly, to take a look at the processes, because just to see where or if things can be streamlined. Not about the business licensing side.
Right.
We do that. We have a process that we do at the city to try and see where we can work out bottlenecks or change forms so they're simpler, et cetera. I'm just curious about, again, they're really small business owners who, every day matters when they're getting a new business up and running. And so just curious how often we take a look at the forms and the procedures and the processes to see, not that we want to cut corners, but just to see where we can kind of alleviate a bit of stress or make things clear or just streamline, right, I guess I said, forms and processes. Do we do that?
We would do it on an individual basis. As far as when we go in for our visit, we do pre-operational inspections, and we do our inspections, we really try hard to build a relationship with the operators to help them through whatever they need to get done. And the information that we collect in the outset, if somebody's interested in opening up a food premises, is very, very basic. Who's the operator, where it is, what their intent is, and then we take it from there. We'll follow up very quickly to review what they need and to help them. If they have any feedback for us, we have streamlined our e-form on the website over the years as well. So we would take that information into account as we get feedback. From a special event point of view, we have been successful in meeting with special event operators. I wouldn't say annually, but upon request or upon interest, we would meet with them to review what the requirements would be and to help from that educational standpoint. And we work with the municipalities on that. We sit with a couple of municipal working groups around special events to support that. If they are interested in doing that, we would definitely support that.
Okay, thank you.
Councillor Rodriguez?
Yeah, thank you, Chair, and thanks for the update. When you were here last year on this report, there was some really great conversation around temporary events, food trucks, and the growth in that service that your team provides. Could you maybe just speak to some of any changes that were made this year, as it related to some of these emerging businesses, how we can be perhaps a bit more flexible on temporary events and
Right.
collaborating with those event licenses, I think, that you just spoke to. I'm just curious if you have any,
Yep.
what we experienced last season and
Right.
maybe what we can look forward to in the season ahead.
Thank you for the question. Through Chair, yes, we actually saw an increase in the events that we assessed last year. From last year, from the time we were here last year, we actually we went away and we created a YouTube video that's on our web, that's accessible through our webpage. And through YouTube, it's translatable. It's basically running through our key food safety practices for special events to help. It's just another tool in the education toolkit that we use to get our information across. I think, can't remember the exact numbers, but we assessed a number of events, and we've done, from a special event standpoint, we assessed over 430 special events. So we didn't inspect all of them, but we did a risk assessment to see which events we would require to inspect. And that video got some good feedback. And we've also done an educational session with some operators in the Kitchener area as well, upon request.
Appreciate that. Thank you, Chair.
Councillor James?
Yes, thank you. Through you, Chair. Thanks for the report and the presentation. Just I guess it's a practical question. So we go to many events and there's a food vendor that is there, and I know there's probably been a permit through the organization who's organized it or the municipality. Is there anything that those caterers have to have on them at the events? I'm just wondering, because I mean, realities are sometimes there's so much food, and yes, there were permits, but something that says, that we've inspected this or they've gone through some sort of certification. The videos are lovely. I did watch them. They're great. But something that is there, because I mean, there's so many caterers just popping up lately.
Yeah, that's why we work really hard to get information up front from the coordinators, the event coordinators, and try to follow up with the vendors that have applied to be part of that event. And we want to try to follow up with all the vendors to make sure they're inspected. If it's not here from another health unit, we follow up with our colleagues in other health units to make sure they're inspected. On site during the event, vendors who are preparing food, they should have some sort of certified food handler certification. That's one of the things that we ask in follow-up. If we inspect that particular event, then we'll ask for it. We do promote having signage or check that we inspected signage, but during special events, it's very temporary. even if they put it up, it's gone. Like, it's just very chaotic in some of those special events. So we try really hard to do a really good follow-up, do the education piece, and if it's assessed to require an inspection, we'll follow up on that when we go. And we do, not that we target anybody, but we do focus on those vendors that have more complex food preparation, or what we would consider a bit more higher risk.
Yeah, I think that's just it's something I think many residents, even myself, is aware of. Kind of the foods there, like how is it prepared? Is there anything to kind of validate that this is they've gone through the proper channels for food handling? And I guess the other thing you just touched on it was around the complexities. It says in the report that there's increasingly more complex, inspections. Can you just expand on that a little bit? What you mean by that?
There's, as the region has, shown some strength in the growth, there's also a lot of different ideas out there. It's innovative ideas. People want to try different things. Obviously there's an obvious global influence of more people wanting to share their foods and their cultures, and our inspectors have to stay on top of that. So we do our best to work with them, but also follow the regulations and make sure it's being done in a safe way. But the innovation has been very significant as well. People trying different ideas, which I get. They want to try to promote whatever product, try different ideas, try to get that interest. So.
Okay, thank you. I think that's something you'll be continuously trying to keep up on how intuitive and innovative people are with their food and how it's done. So thank you.
Okay, I don't see any more questions from committee members. Thank you for the presentation.
Thank you.
On to items 6.2.2 and 6.2.3, paramedic services response time performance plan and the paramedic service annual key performance. And so these are two separate reports for information purposes. And I'd like, if committee would agree that we don't do any questions on the first report, we take both reports and then deal with questions at the end, being there's a similarity between the both of them. Hey, Chief Richards, welcome.
Good morning. Thank you for having me here today. I'd like to welcome our new CEO, CEO Batty, and thank Acting CEO Getsky for all his support over the last couple of years in what was, I'm sure, a challenging role. We're happy to be here today, and you'll see that I have some members of the team here to report to you on our key performance indicators for 2025, which was largely a successful year for us in terms of improving response times and other service to the community. As you know, there's a legislative responsibility. The reason these things are in two reports is the response time performance plan report is a legislative responsibility that I must now submit after it's accepted by Council for information by the end of the month to the province. That's a requirement. It's legislated, and I've talked about that before. If you can go to the next slide, please. I just would like to start with some acknowledgements. And first of all, to our public health, epidemiology, and analytics team who are hiding over there, trying to look inconspicuous. They do tons of amazing data analysis and data collection for us and make sure that our data is of high quality. You can't deliver an emergency service, or I would argue any service to the community, without really, really strong data driving those decisions. And so kudos to James, Monica, and all the HDAs because they're very helpful to us. Also to our leadership team, our paramedics, our logistics, our administration staff, professional practice and quality insurance, training, and information technology groups in paramedic services. The results that I'm about to share with you, and hopefully you've read the report before the presentation, are the result of the hard collective work of all of those individuals and the collective impact they all have. And the paramedics can't do their job, for example, without a strong logistics team. If the logistics team isn't strong and getting the ambulances ready for service and certifying the equipment and maintaining it, then paramedics don't have the equipment and ambulances and the fueled up rigs that they need to respond to calls. And that's just one example. So kudos to all of my staff as well. Also, regional partners, including public health, human resources, information and technology services, finance, facilities, and fleet. Again, this is their work also is contributed to these positive results. And so I would just like to acknowledge all of them. And then finally, the big driver for improvement is also that Council in the past number of years has really improved or approved service enhancements that have allowed us to get our service levels and the amount of vehicles we have on the road and the amount of ambulances and paramedics we have responding right-sized to the call volume. And so the combination of all of these acknowledgements you see on the slide are the results I'm about to share with you. Next slide, please. So really briefly for key performance indicators, despite an increase in vehicle responses and 911 call volume, we did see a decrease in unit utilization. Unit utilization is usually an output of making sure you're right-sized, but the important thing about unit utilization, which I'll talk about in a bit more detail, the lower the unit utilization is, the more vehicles you have available to respond to the 911 calls that come in. So that's the connection there for that. Response times have improved relative to 2024. In 6 of the 7 municipalities, they did improve, and in one municipality, they stayed the same, but we saw no decrease in response time improvement or performance. A big driver of system performance has been our continued efforts on ambulance offload times with our local hospitals, and I'll get into that in a minute because they are better than they've ever been. And also another great output of all of this, and I know it's really important to council because when I got here, they were called code reds, which was when we never had any ambulances available to respond to 911 calls. We've had a significant, we call them code zeros now, and have a significant improvement in the code zero metrics, which again shows the health of the system. It's important to acknowledge, though, that there are very good system improvements for the public and for the people we serve when they call 911. But the other improvement is on our staff mental health and well-being. In particular, in last year, we saw almost 29.1% decrease in end-of-shift overtime for paramedics. That is really, really significant. If a paramedic can come in and work really hard for 12 hours and go home when that strike clock hits the 12th hour, we know that they're going to be more well and more able to come to work the next day. So that's really significant. And a modest increase on missed meal breaks. Our paramedics in their collective agreement get there are 2 acknowledged meal break periods, and we've seen about a 7.3% improvement in missed meal breaks, which again, if they get some downtime and they're able to get some food into them and they can be healthy, they're going to be better responders and better paramedics out on the road. So we're really thankful about that. Next slide, please. In terms of vehicle responses and unit utilization, you'll note that we've had a 3% increase in vehicle responses compared to 2024. That is also an increase over 2023. I think in 2023 was a 2-point-something roughly increase. So we are starting to trend. The call volumes are starting to go up again. We responded to just over 66,600 unique 911 events last year. And the reason there are 76,000, almost 77,000 vehicle responses is some events require more than one resource in order to support the patient. So sometimes you will see multiple resources going to a car accident, for example, things like that. And our projections show, again, this is the amazing work of our EHA team, our projections show that we could see as many as 83,600 vehicle responses for 2027. So that's not for this year, that's for next. And doing those projections are really, really important because it helps us plan rather than react, if that makes sense to everybody. Unit utilization, lower across all but 2 hours of the day, and it was a real significant improvement, and this is largely due to the improvement in ambulance offload times and the council-supported enhancements over the last couple of years. We're now at that 35% benchmark, which was the previous master plan's goal. So we're really happy that we're there, and it's really happy that we achieved it at the end of that master plan, and now we're starting a new master plan, which council approved in the fall. Next slide, please. I already mentioned this, response times have improved overall. The 80th percentile has improved by 8 seconds and improved or maintained across all 7 municipalities. And it's important to note that response times are impacted by ambulance offload times, are impacted by resource availability. So the less units, less paramedics who are stuck in hallways, the better our response will be out in the community, and also making sure we're right-sized in terms of the number of resources we can put at peak deployment and through the night. Next slide, please. Really pleased about this metric. This has been a heavy lift for us and all 3 of our hospital partners. I guess it's 2 now with the merger of REN. But in 2025, we lost 156 days, or average of 13 hours per day, the equivalent of nearly 1 12-hour ambulance shift per day due to ambulance offload times. But if you see the next bullet, the previous year, that was almost 3 12-hour ambulances lost to ambulance offload time. That is all hours that don't cost us any more money because we're already paying for the resources, but it's all hours going back into the system to improve response times and service to the community. And we were really excited to see that in October of 2025, we had the lowest monthly total of ambulance days lost since 2021 to ambulance offload times. So that's a real significant improvement, and we are really, really pleased and thankful that our hospital partners have made this a whole hospital priority. I've mentioned this before in previous reports. You know, in the past, ambulance offload times and offload delays were looked at as an emergency room problem or a paramedic service problem, and really it's a patient flow problem. It's actually very connected to the presentation Dr. Mathers provided regarding how the long-term care homes can play a role. When patients are in the right environmental conditions to receive care, then we see better system improvement overall, and kudos to Sunnyside and all the work they do. And we have some strong partnerships with them in that regard. But all hospitals have made this a whole hospital priority, so we're really thankful about that, and know that counselors across the horseshoe here have advocated a lot to hospitals about improving this metric, so thank you for your advocacy as well. Next slide, please. Regarding resource availability, again, a really, really strong improvement in metrics, and you can see it going from right to left on your screen there. And in 2023, we had 132 Code Zero events, down to 42 in 2024, and only 5 in 2025. And there has not been a Code Zero event in the last 9 months. So really, really significant. And again, it demonstrates when we right-size the service and we deploy our vehicles where they need to be, we're going to get better results. So we're really, really pleased with that. Next slide, please. So this is the part where I have to do my legislative function about reporting to you about our response time performance plan. All of our metrics have increased. Now, there's a couple of reasons for that. The most important metrics are on sudden cardiac arrest, CTAS-1 and CTAS-2 patients, because they are your sickest or highest acuity patients. In order to prioritize those and improve those, we increased the compliance targets for our lower acuity patients. And I mentioned that to you when I asked for a change to the response time performance plan from council, because we want to make sure we're prioritizing the sickest patients first. So if we can go to the next slide, please. So the first bullet is my explanation about, for CTAS 3, 4, and 5 calls, a few years ago, we were targeting like 12-minute response times. And those are patients who can safely wait if they've been properly triaged at the dispatch center. They can safely wait for longer than that. And the theory and the evidence shows that if we ask those patients to wait, or the system has those patients wait, it means when the sudden cardiac arrest call comes in, or the CTAS-1 chest pain stroke patient comes in for a call, we will have a resource that can respond to it. And so it's about protecting our resources for your sickest patients. And, you know, there's still tons of system pressure and there's still room for improvement, but despite that, you know, I'm really proud of our team. We, I think, deliver really excellent patient care. Our staff work in really, really difficult circumstances, which I've reported on before. And they do so with a smile on their face and compassion in their heart, and really, really deliver strongly. So we're really pleased about that. Next slide, please. This is where we've seen a real big improvement regarding sudden cardiac arrest. You can see that the Ministry of Health's target is 50% of the time a defibrillator is to arrive on scene for a sudden cardiac arrest in 6 minutes or less. We have a regional target to achieve that 6 minutes or less 70% of the time. And in 2025, we hit that target, and it was the first year we'd hit that target in a few years. So again, a demonstration of improvement. So thank you. Thank you for your clapping. I appreciate that. If you can go to the next slide, please. And the rest of these are just showing you the improvement from 24 to 2025. Again, if I can draw your attention to CTAS 3, 4, and 5, the reason you've seen such a marked improvement in the percentages, for example, CTAS 3 from 80% to 92.3, is because we lengthened the time target. So that's the biggest reason you've seen that improvement. So it was a data change. Next slide, please. I often get asked about what are the strategies we're continuing to do to mitigate challenges within the system. Obviously, one that we will continue to do, and we meet with every hospital every 2 weeks, is to continue to work on system improvements and patient flow improvements for ambulance offload times, because that is work for the leadership team on our part and our important hospital partners, but it results in getting more time back into the system for paramedics out on the road responding to calls. We want to utilize and continue to utilize provincial funding from the Ministry of Health for the Designated Offload Nurse Program. That is funded currently at just over $1.5 million a year. That allows us, and it's 100% funded, nothing from the tax levy, and it allows us to fund a designated offload nurse position in all 3 hospitals 24 hours a day, 7 days a week, and that is, again, what's helping drive these improvements. And we just submitted our proposal for the 2026-27 provincial fiscal year, and hopefully we will see that funding increase, if not at least stay the same. We want to continue expansion of the patient care model standards that the province is helping enable, and those are things like treat and discharge, treat and refer, and alternate destination. For treat and discharge, treat and refer, the goal is that give paramedics the tool to release a patient from care at the scene rather than take them to the hospital, and we're continuing to focus on those efforts. And then obviously for alternate destination, you've heard us speak and support Heart Hub partners at the Horseshoe here about setting up a clinic in the community for mental health and addictions patients that we could eventually transport to rather than transport them to Emerge. And I think we talked about that just a couple of months ago, if I'm not mistaken. Also, furthering advancement of community paramedicine program to address complex patients that have a high utilization rate of 911. That's important. And in May, a report will be coming to the committee regarding our performance for the community paramedicine program. So happy to report on that in May, but also take questions today if necessary. And then the other leap we made was in early January, we reassigned operations superintendents into the dispatch center run by the Ministry of Health. We're, I think, the 5th or 6th community across the province to do this. What this means is now we have right in the dispatch center on the floor where calls are being taken and resources being dispatched, we have a representative in there 12 hours a day, 7 days a week, helping make sure that our deployment plan is being followed accurately, helping support our Ministry of Health partners in managing difficult 911 calls, helping making sure our resources are getting off work on time, all those types of things. And we really are starting, in the first couple of months, we've seen some gradual improvements, but in terms of the relationship and the partnership with the Ministry of Health, we've seen large improvement and are hoping that that program will continue. Next slide, please. I think I reported to Council in the fall that we got a new dispatch system on December 4th of last year. So we've now just hit about 3 months of that dispatch system called MPDS. And we're excited to see how that dispatch system and those changes will also improve the metrics. Because the old dispatch system, which I've reported on a few times, was fairly old, fairly antiquated, and it was like a blunt force instrument in terms of trying to get resources to the right calls. And so we were responding 70% of the time, code 4, lights and sirens, to calls of all natures, and then finding out when we got there that those patients weren't actually that sick. When that was happening under the old system, it meant that if I was being dispatched to a code 4 abdominal pain the patient had abdominal pain for 3 days, I couldn't be reassigned to a code 4 cardiac arrest. So we weren't utilizing our resources effectively. Under the new system, MPDS, now the highest acuity calls get a specific designation called code purple, and we can reassign from any of the lower codes to making sure the code purple gets the quickest and most timely response. And so it's gone to that 5-level system. Our staff, I think, have largely embraced it. We've been working with our dispatch partners to making sure it's being managed effectively, and we are seeing improvements in that regard. And I hope to report a year from now that that improvement has been really significant. We have changed how our emergency response units are being utilized. We have now staffed them with advanced care paramedics. Previously, they were with primary care paramedics. And the prevailing evidence and theory on that is the advanced care paramedics, we don't have a lot of them in the system. We roughly have 45 to 50 out of all of our staff are advanced care paramedics. So when only 4 or 5 are on duty in a day, we want to make sure we get them to the highest acuity patients as often as possible, because that's where they have their most impact. So by putting them in response units, that allows them to zoom around and attach themselves and get dispatched to those patients as much as possible. The other thing we've done is move them, primarily the response zones are in the central core of the region. Previously, as council knows, they were assigned to a post in rural townships. The reason we've done this is by putting response units in the urban core, and hopefully and what we are seeing is them responding to calls and then canceling off ambulances altogether because a single paramedic was able to manage the call from start to finish. What we've been able to do with all this other resource availability is reprioritize rural areas to actually have ambulance coverage, not just response unit coverage. And one of the advantages to that is a single resource managing a call in a rural township instead of the response unit and the ambulance, which is obviously a little less cost effective. We also wanted, part of the master plan that you approved in September includes a recommendation to develop and enhance a clinical response strategy for all areas of the region. So this change to response units and how we utilize advanced care paramedics is part of that. And we want to make sure, as I mentioned, that we're prioritizing ambulance coverage for those communities. And then making sure, as I already mentioned, advanced care paramedics are getting to the highest acuity patients as often as possible. That's why they took the training, is to be able to make the most impact on our sickest patients. The other thing that we take a lot of pride in is that we don't make these decisions on a whim. We make these decisions based on data. And so again, with the support of our EHA team, we have dashboards internally that we use to adjust deployment plans accordingly. And if we see data trending in the wrong direction, we'll make a different decision. If we see it continuing in the direction we want it to go in, then we know we've made a good decision and we can make those timely decisions more regularly. And then the final plug, I guess, is the next thing we need is a mitigation strategy, is council support to continue to implement the recommendations in the master plan that were approved in September. If I may remind council, that plan indicated that we would have a 60% increase in 911 call volume by the year 2035. So as we see those call volumes increase, we need to make sure, right now that we believe the service is right-sized to manage demand, but we're going to need to continue to enhance service to manage that demand, assuming, I think, that we all want response times to be positive in terms of improvement, and we all want patients to get the care they need when they need it. So that is all I have, and I'm happy to take any questions.
Thank you, Chief. We do have quite a few questions. Councillor Shantz.
Thank you. And thank you, Chief. I know that your day wouldn't be complete unless I commented on offload delays, and I'm so glad to see them drop as they have. And also to just make the point that, you know, when we get things under control, it can be expensive and difficult to get there. But in the end, the investment in the total system is well worth it. And I think that's something that we as a council need to remember when we're advocating as well to the province, that, you know, we might not see all of the benefits here, but the system as a whole will see benefits. And hopefully we can get a little better distribution of funds accordingly.
Councillor Wolf.
Through you, Mr. Chair. Thank you, Chief. Great report. Congratulations on providing excellent patient care and excellent response times. I think you've improved in every area. Under offload delay hours, is the Cambridge Hospital still your greatest number of hours? And if so, why do you think that is?
Through you, Chair. Yes, unfortunately they are at this time, although it's important to acknowledge that all three emerged sites have greatly improved. I think that Cambridge has some unique challenges which are similar to our challenges in supporting the needs of the Cambridge community. And one of the biggest ones is they're the only hospital in town for south of the 401. So they tend to be a catch-all for patients of all types and all acuity, whereas for Wren, they have two facilities currently that are fairly close together that can support each other in that regard. All that being said, I think that Cambridge is on an improvement journey. In fact, I know they are because we meet with them regularly, and their executives say we don't want to be third, we want to be first in terms of this metric. So some healthy competition amongst the hospital sites to drive improvement with each other is really helpful. And I know that they're working with REN to say, hey, what's working in your department? Maybe we can bring it to our department. But it is, currently they are the highest 90th percentile offload delays for us, yes.
And I just wanted to comment on attending, I think, your shield ceremony for new recruits.
Yeah.
How impressed I was by the people going in to become paramedics and by their diversity and the range of backgrounds. So looking at that recruit class, I know we're going to be in good hands in the future.
Thank you. Through you, Mr. Chair, I really appreciate your comments on that regard. We're really proud of our recruitment strategies. And just a shameless plug, you'll be getting an invitation to another epaulette ceremony for early June shortly.
Okay, thank you.
No problem. Thank you.
Councillor Hunick?
Thank you, Chair Erb. Thank you, Chief Ridges, for coming and presenting this very encouraging report. I know there was more to your report than offload delays, but the improvement, vast improvement, is very much encouraging. So I just want to follow up on Councillor Chance's comments around how did we get such a vast reduction in offload delays, and how do we ensure that we maintain that, knowing that it's best for patients and it's best for first responders?
Thank you. Through you, Mr. Chair, it's an excellent question. I think the answer to what got unlocked was really about collaboration and partnership between our leadership team here, some of whom are in the audience, and hospital leaders, both at the manager and director level in the emergency rooms, but also senior vice presidents and CEOs at the hospitals. I've done a lot of work across the province for offload delays through the Ontario Association of Paramedic Chiefs, and the one enabler that we think is the most important is when senior hospital leadership says, offload delays are not acceptable in my facility, because if it starts at the top, staff will follow. And I've said to my staff, how do you expect a charge nurse who's really busy on a Saturday night to worry about ambulance offload times if it's not a priority for the whole hospital on weekdays, for example? And so I think the biggest enabler, to answer your question, Councillor Hunick, is that we have senior leadership buy-in from the hospitals, and they've made it a whole hospital metric. In fact, ambulance offload time is a metric now that every ward in the hospital sees it at all 3 sites. So a med-surg ward sees it, the mental health ward sees it, every ward sees it, so they've all created buy-in for it. Because again, it's about patient flow. We bring them patients. As you all know, you've all used the emergency department. Patients go to the emergency department by taxi, by private means. And it's where can they, once those patients have been assessed and stabilized and emerge, where do they go from there? And so the hospitals have done, I think, a really, really bang-up job of improving systems in that regard. And I think the other enabler is that Ontario Health and the Ministry of Health have made this a priority. Every 3 to 4 months, I meet with senior executives of the hospital, the Assistant Deputy Minister, the Ontario Health Deputy Minister, and they hold us to task to our metrics and say, okay, the provincial expectation for ambulance offload time is 30 minutes. Why are you at 40 minutes? Why are you at 60 minutes? Why are you at 20 minutes? That type of thing. So their advocacy and pushing the hospitals to improve has been very helpful as well.
So just to make sure I'm following you correctly, the fear of the rebound offload delays is lessening because it's a priority for the entire system, yes?
Yes, through you, Mr. Chair, I would agree with that. We do see inflections in the data. So for example, I've mentioned this before, December and January tends to be respiratory season in the healthcare system. So we do see an increase in ambulance offload times for those months.
Yeah.
And we know to expect it.
Okay.
But if we can keep ambulance offload times the other months to below 30 minutes, when it jumps up to 35 minutes or 40 minutes in those months, we can actually we can manage during those times. Not a couple of years ago, the ambulance offload time in the 90th percentile was over 2 hours. So it's really, really significant improvement.
Very much.
Thank you.
Councillor Rodriguez?
Thank you, Chair. And Chief, thanks for a great news story this morning. And thanks to the team that's here and on the road for helping us get there. 2 questions for you on the master plan. So we've approved a plan. Could you comment on when, is it through the annual budget cycle that you expect to be coming forward with your next year's strategy, or is there, some type of report that comes leading up to budget to help sort of begin those conversations? I think, to your point, we need to not let our foot off the gas and to keep understanding what the incremental steps need to be. So if you could comment on that.
Yeah, thank you. Through you, Mr. Chair. I really love the question. For us, the master plan and all the recommendations in it is our guiding document for the next 10 years. Some of those recommendations do not require financial resources, such as developing a clinical response strategy. That's something that's the responsibility of myself and my team. Coming up with other strategies that are more system improvement strategies than they are resource improvement strategies. However, in order to manage call volumes and other things, that incremental improvement will be required. The general rule is we will use the master plan to inform our budget asks. That's the general rule. As a quick example, the master plan did call for in 2026 an expansion of our rapid response unit program. But unfortunately, due to fiscal pressures, we were not able to increase FTEs and stuff like that for this year. So that's why it didn't go through. However, you can expect that I'll probably be putting it in for the 2027 budget, if that's okay. So.
No, that's great, and appreciate that. I think that's it's great to know that there are those things that are low or no cost, and the bigger asks. Similar to Councillor Chauncey, I think it wouldn't be a conversation with you if I didn't pick up on our budget conversation around community paramedicine. I think it is such a great program, and there's some promising news, I think, from the province that this is a fully funded program, and that you said you'd be coming back in May. Can you speak to the status of that program, what we know now, sort of a few months out of budget? Because I think this is a program we need to keep in the spotlight.
Yeah, and through you, Mr. Chair, thank you for the question. Our overall strategy right now, just to remind Council, we're about 90% traditional 911 response and 10% community paramedicine. And the way of the future for paramedic services is to change that ratio so that you have 25, 30% community paramedicine and 70% 911 responses, because the goal of community paramedicine programs is to support patients earlier in their needs so they don't need to call 911 at all. That's kind of the primary goal. I can tell you that, save and except for one position, we're fully staffed in our CP program now. And we are, to your point, fully funded. The Ministry of Long-Term Care announced that CP LTC funding, or Community Paramedicine Long-Term Care funding, as it's called, was going to be base funded instead of annual grant funding, which is a real big kind of milestone for us. That announcement was made in August. That's supposed to take effect April 1st of this year, but we have not received the funding letter yet, which is also not entirely surprising. That is sometimes the way the province works, as many people around the horseshoe knows. But it's my sincere hope that once we get the funding letter, it'll be the same as what we previously received or increased. And then over time, we'll use, again, data to inform metrics to say, hey, you need to continue to invest in us at a greater rate. And as a reminder for councillors, that's 100% funded by the province through two ministries, both long-term care at about $3 million a year, and then Ontario Health through about $300,000 a year. And, it's a huge value for the dollar, because if we can get community paramedics supporting people in their places where they live with complex medical needs, and they don't need to call 911, it actually saves the system money because they're not going to the hospital and all those types of things. I think that there is room for growth in that program that we certainly want to see, and we've had conversations with REN about helping them with discharge planning for patients who are being discharged from hospital, and also conversations with Peter and his team in community services and Sunnyside specifically about how to support those areas. And then one of the other things in our annual business plan for this year for community paramedicine is to provide clinic offerings in regionally owned supportive housing buildings, because we know that those buildings generate a lot of 911 calls, so rent geared to income, those types of buildings, social determinants of health. I'm sure council knows all about that. We want to put clinics in those places 1 day a week, 2 days a week, 1 day a month, whatever it is, whatever the building needs, with the theory being that if we can provide supportive kind of preventive care, then that building, we should see a decrease in 911 calls from that building. So we're starting with the regionally owned buildings, and then with a long-term goal to expand to other not-for-profit housing groups.
Amazing, thank you. I look forward to the May report, and if there's anything we can do in the meantime, please let us know.
Thank you.
I want to remind committee, I have a few more speakers, Councillor Fox and McCabe and Nowak. And we do have a hard stop for Ramadan at 1 o'clock. And we also are trying to work around the Conservation Authority update and delegations coming at 1:30. So with council's indulgence, we might just take the three remaining speakers and then try and move on to the rest of the agenda if we can.
I'm going to talk real fast. Thank you very much for all you do. You did a great job. I was on the master plan in 2014, and you've come a long way. Thank you.
Thank you.
Thank you, Councillor Foxton. Councillor McCabe.
Thanks very much, through you, Chair. And thanks to the whole team, as others have said, for tremendous improvements. And the data is really, really helpful. So thank you very much. I'm curious, and you don't have to answer this right now, but when it said that I'm curious about how much time and how the time saved translates into staff. You know, where it said that it saved 3 shifts of 12-hour shifts 6 times per day. Did I get that right? Does that mean that 6 paramedics? Anyway,
you're looking
I would
at
just
slide. Maybe while you're asking your question, just got to find
I'm just curious what that looks like in terms of actually staff and impacts there. So you can just email us that if you'd like. But I just 153 days. I'm just curious what that 453 days. What that actually looks like.
If through you, Mr. Chair, I can give a more detailed response via an email response if Commissioner Wong's okay with that.
Okay, thanks.
Is that okay?
And then the other question I had was, because of the prioritization of issues, are we doing, or your team doing some more communications out regularly to residents to let them know, if you call and it's not you can call, an ambulance might be sent, but then maybe changed en route because, if you've sprained your ankle, a heart attack takes priority. Is there that kind of ongoing publication or communications happening as well so people understand the priority system that's in place?
Great question through you, Mr. Chair.
And I guess part of it is, and maybe it will eventually, over time, help reduce maybe some of the calls we get, because I think some of the calls come in, they're not emergencies, right? They're
Correct.
yeah.
Yes. So through you, Mr. Chair, I'll answer your last point first. Yes, we respond, of those 66,603 calls we did last year, a good portion of them would not have been deemed medical emergencies, very clearly, because they're CTAS 5 or CTAS 4 patients. I think there's a couple points to that element. One is that often people call 911 because it's the time of day or it's a holiday or whatever it is, and they can't get access to healthcare through another means, so they call us. We tend to be a safety net in that regard and take that responsibility quite seriously. I think we also need to be careful. Yes, we do some social media messaging about these things, but I'll give you an example. I was speaking to a colleague from London Ambulance in the UK, in the NHS Trust there, and they went through on a huge when to call 999 campaign and immediately saw, after they finished their campaign, an increase in 999 call volume. So you have to be really, really mindful about how you position your messaging about that. But and the last thing I'll say is we did 4 or 5 public information sessions leading up to MPDS being implemented. And I think other than, I think we maybe had 12 people attend all four or 5. So despite best efforts to put ourselves out there and be ready to answer questions from the public, we didn't get a lot of uptake in those sessions.
Maybe it'll be a learn to do by doing. And a comment, I just wanted to thank Dr. Wong. Last Wednesday, you and I and many, about 100 other community leaders were at the University of Waterloo's Healthy Waterloo Summit, which the goal is to create the healthiest campus and then the healthiest community in Canada. And I just think it was really important to have you there because, a healthy campus, it's more than just primary care and, acute care. It's really about a whole of community approach. And public health, of course, obviously plays a big, big part of that, as do area municipalities. So just wanted to thank you for there'll be much more coming out of that. And I think it's really exciting opportunities so thanks for your participation.
Thank you, Councillor McCabe. I also wanted to mention that Commander Bettles was there for paramedic services as well, because Chief Richards wasn't able to attend that day, but he sent the commander medals.
Councillor Nowak?
Yes, just very briefly, I just want to congratulate you on a fantastic report. I think you and your staff have an awful lot to be proud of, and I hope you I hope you understand that council has recognized you for that. You did answer my questions between yourself and a side chat with Dr. Wong a little earlier. My questions and concerns have been addressed. I do have one question, a quick question. You may not have an answer for it right now. When you have the ambulance at a station in rural areas, it does get called into, occasionally it'll get called into the city if needed. Do you keep the stats on how often that happens and how often that station wouldn't be populated with an ambulance?
Through you, Mr. Chair, thank you for your question, Councillor Nowak. I'm happy to continue the conversation with you to make sure we support our rural communities. I think we don't have that data like fresh right here, but I certainly suspect our epidemiology people are going, how do we get that data for them? So I'm sure we can work on that. And just for all of council's awareness, wherever we deploy vehicles, whether it's response units or ambulances to stations or street corners, at any point they could be assigned calls not in that area. It really does depend on where the call comes in and what's needed at the time. And if we've had, for example, we could have tons of resources in downtown Kitchener and then have a really significant call requiring a lot of those resources. And then that means the next call that comes into Kitchener might need to come from Waterloo or from Cambridge or from outlying areas. So it's we call it dynamic deployment. We put them where we want them to go, expecting where we think the calls will be. But if the calls are somewhere else, then we send them if they're the closest vehicle, if that helps.
Thank you very much.
Thank you.
Thank you, Chief Richards, Dr. Wong, and your staff for this good news report. Offload delays have been a big issue, and I remember from our previous term of council, it coming up, and Mr. Murray was the CEO at that time who committed to beginning conversations with our health partners to try and solve the problem. So there's been a long process, and congratulations on locally that we've been able to make this work. Good news. Thank you.
Thank you. Appreciate your support. Thank you.
Item 7.1, council tracking list is for information. Number 8, is there any new business? Our next meeting, number 9, is April the 7th, 2026. And we are now going to move into, I'd like to consider a recommendation to go into closed session, moved by Councillor Fox and seconded by Councillor Rodriguez. If you could use your e-scribe icon to support that. And that we're going into a closed meeting of the Administrative and Finance Committee and Sustainability, Infrastructure and Development Committee to be held on March the 10th, 26 at 12:30 in the Waterloo County Room in accordance with Section 239 of the Municipal Act 201 for the purposes of considering the following subject matters: discussion regarding labor and employee relation matters related to an internal employment program and receiving information explicitly supplied in confidence from an external organization related to the Charles Street Terminal. That's been carried. I would entertain a motion to adjourn the meeting. Moved by Councillor Fox and seconded by Councillor Wolf. Use your e-scribe buttons to indicate your support. We're voting to adjourn. Pardon? Is there any objection? I think it looks like everybody's hungry and ready to adjourn. We're adjourned.
Did I miss something?